I thank the organizers for this opportunity, and I welcome my three team panelists. So we're going to talk today about brain tumors and specifically about GBM. So these are my panel members. So the roadmap for today is going to be that I'll present the case details of GBM with the disease profile, and then we will look at management for this patient at the initial diagnosis and at recurrence, and I will show you the supporting evidence for the same. So this is a real patient, not a hypothetical one. So this patient was seen on 2nd of June 2020. She's a 38-year-old lady. She presented to her GP with an episode of sudden onset of GTCS, headache and nausea, and was investigated for the same. So let's start with what would you do to find the cause? Team A, then B and C. So Team A is from the government setup, Team B is partially funded and some insurance, and Team C is they can afford anything under the sun.
Yeah, MRI.
Okay.
MRI of the brain.
So that's available in the government scheme.
Not at all places.
Okay. So if not, then you will do a CT scan.
Then a CT scan. Yes.
Okay. So Team B and C, I think you will definitely do an MRI.
Yeah.
Okay. So this is the MRI for this patient, which was done on 2nd June. And I will just show you the 4 films, and then let's see what the findings were reported by the radiologist. Okay, so this was the salient features given by the radiologist, that there is a large heterogeneous necrotic enhancing SOL in the left frontotemporal region. There is perilesional edema and midline shift. So what would be the next step? Team A, then Team B and C. What would you do for this patient?
We would like to go for maximal safe resection.
Maximal?
Safe resection of the tumor.
Okay. So you would want to do surgery?
Yes.
Before that, would you want to do anything? So the MRI showed a midline shift, there was perilesional edema. I think I would first start the anti-edema measures.
Medical decompression
Yeah,
therapy.
so we will do the institute the anti-edema measures. So the clinical features, as we know, for this patient is because of the raised intracranial tension and the tumor infiltration producing the neurological dysfunction. So management, like you said, surgery part, either an incomplete or a complete excision or just a biopsy sometimes, radiotherapy, chemotherapy and biotherapy. So B and C, would you differ on any of these lines?
No, sir.
Okay. So what is the role of surgery in newly diagnosed GBM? Again, opinion from the 3 teams. You said you will do surgery, but the exact. So we'll always want to do a decompression, if possible, a complete excision.
In case of GBM, there is certain role for maximal safe resection.
Correct.
There is ample evidence to show that the extent of excision is important.
So that's what this slide is telling you about the role of excision, whether it's complete or not, and what ultimately is the outcome for these patients from surgery. So this patient underwent a left frontotemporal awake craniotomy and excision of the tumor on 3rd June, and this is the report saying that it is a GBM not otherwise specified. Then the further report that came showed a methylated form of MGM. So what is the survival for GBM not otherwise specified? So I don't think it will vary whether it is a poor patient or a rich patient, so it will be the same. So this is just to show you the median survival, which is based on the tumor type. And if you see the last one, the Glioblastoma Multiforme, it's less than 12 months. So what is Glioblastoma Multiforme? That it's one of the most malignant and most common of the glial tumors. It constitutes about 15% of primary brain and CNS tumors and 55% of all gliomas. As I mentioned, some series, the survival is less than 5% at 5 years. And This is composed of a heterogeneous mixture of poorly differentiated neoplastic astrocytes, glial or its precursors, so-called glioblastoma. Grossly, there are regions of necrosis and hemorrhage, and microscopically necrosis, pleomorphic cells, microvascular proliferation, primarily affects the adults, located preferentially in the cerebral hemispheres. So these are the salient features for the GBM. And people have actually put up a performance status algorithm for these patients, and this is what is shown here, whether their performance status is good or not, and accordingly you have an algorithm for these patients. So once this patient has undergone, I told you there's a 38-year-old lady, she's undergone excision. So what would you do in your government hospital? Team A?
Post-excision, we would like to go for adjuvant radiation along with concurrent and adjuvant temozolomide.
Okay. B and C?
If possible, get the NGS or the PCR running for all the mutations, including the IDH1, 2, ATRX, P53 as prognostic information, MGMT methylation status. If that is
It was methylated. I showed you the previous one.
so
It was
get
methylated.
everything, but treatment-wise, yes, go ahead with planning
Correct.
temozolomide as quickly as possible, and then RT as soon as she's fit for RT.
So although you get those things done up front, your treatment essentially is going to be the same. You will not base your treatment up front based on any of these molecular markers.
So probably along with the temozolomide, there has been data for lomustine addition in concurrent radiation and adjuvant radiation. Still, the standard is the temozolomide. If a patient is young and fit, everywhere the guidelines do tend to recommend addition of 2 agents if possible, if the patient is young, fit and MGMT methylated.
Right. Team C?
Yes, temozolomide concurrent with adjuvant temozolomide. One thing, IDH is negative by IHC, but you can always get sequencing done for IDH. And we know that the certain proportion of patients who are long-term survivors are actually IDH mutant. And as Dr. Bharat pointed out, getting NGS done is also a valid option.
Yeah.
So IDH will be negative in primary GBM mostly because it is not a marker for primary GBM. It is a marker of transformation. When you have transformed glioblastoma, then it will be positive.
Correct.
Yeah. So it will also tell you whether it's a primary GBM or a secondary GBM if you do the IDH.
Sir, I have a query about dual agent. What is the additional benefit of adding lomustine to temozolomide?
Yeah, like I said, there is some data.
But how strong it is to recommend for a routine
Yes,
practice?
Team B, since you made that comment.
So definitely the loco-regional and overall is there, especially if a young fit patient is there, you should definitely discuss the option for adding the lomustine.
What is the magnitude of absolute PFS or overall survival benefit?
So in GBM, it's a bad biology as we have to start with, and all across the table you put it across, the preference is to give in young fit patients the addition of lomustine. As I said that it's not a standard of care because you don't have a phase 3 clinical trial and you won't have it in near future also, but yes, across the group people have a discussion on it.
Okay.
So just to tell you, people here in the audience would not have used lomustine or any of those drugs. My days, we did not have temozolomide, so we were using those as the first line.
And I'm sure sir will remember it's not at all an easy drug to use.
Yes.
The neutropenias.
Lot of myelosuppression.
Myelosuppression
Yes.
can be so prolonged that the cycles can go once in 3
Yes.
weeks, 3 months.
That's why we used to do it once in 6 weeks and check as well. Yeah.
Sir, one doubt from my side.
Yeah.
We know the disease biology. If it is an IDH wild type, if it is MGMT unmethylated, it's a poor biology disease. Do I give temozolomide day 6 and 7 also? Is anyone practicing that?
Is it? I don't think
There are no recommendations for that as of
it is-
now. No.
And I don't think it will not change the thing.
Yeah.
And for what Dr. Vikas was telling, so there is a study comparing lomustine temozolomide versus temozolomide alone. It has shown improvement in progression-free survival, but the study has multiple issues with that. The recruitment and the number of patients analyzed, there are multiple dropouts. Even though it's a positive study, there is acceptance of that study because of the problems with the study design and recruitment. That's why it's generally not accepted. We are awaiting for the data.
Yeah, and as Bharat said, the myelosuppression can be really very prolonged.
Dr.
So-
Govind?
Yeah.
Sir, really sorry. Dr. Rakesh wants to make a comment.
Yeah, sure, Rakesh, go ahead.
Sorry to interject, I don't know if this.
No, no, we want you to talk. Yeah.
So I think it was beautiful points brought out, just couple of quick points because we might lose it later.
Yeah.
As the last expert mentioned, there is actually a phase 2 randomized trial. It is published as big a journal as the Lancet, not even Lancet Oncology.
Yeah.
And it was from the German group which randomized MGMT methylated to TMZ alone versus dual TMZ plus CCNU, and there was an overall survival advantage, not only in PFS, but as was rightly mentioned, there were multiple loopholes, the statistical flaws, and really no one accepts it, and the toxicity was unacceptably high. IDH is a good thing, but you don't necessarily need to do an NGS. You can, it's not so many genes, we know where to do it. You can do very simple RT-PCR Sanger sequencing. In a young lady of 37, you probably need to do it. However, the MRI didn't look like an IDH mutant. They don't have so much enhancement, and necrosis look more like a primary, as was brought out as well. I thought I'd just take these 2 comments and conclude.
Yeah, thank you, Rakesh. So back to our patient. This lady, as shown in this slide, got radiation with temozolomide 100 milligrams, and these are the dates, and was followed up with adjuvant temozolomide 250 initially, and then 300 5 days a month. So as a follow-up, she had a scan on 27 June, and these are the pictures. So this is just talking about brain tumor classification. I don't think I'll go through that. But these are the things that we already discussed about the molecular genetic features with the primary and secondary GBM, and that is how your molecular workup will help you to find out whether it's primary or secondary. And some of the things which are determining the prognosis for these patients are listed here. I think we have discussed some of it already. In the glioblastoma, some of the poor prognostic features are EGFR amplification, EGFR mutation, INK-AKT pathways, P10, and RB mutation. So these are things that are coming up very rapidly. So this is just showing you the pathways in glioma genesis. Starting from the glioma cell, you can have a primary GBM coming up or a secondary GBM, and this is also showing you the various steps and the genetic changes that can occur at each one of these steps. And why we are doing these changes is to assess where exactly your tumor has been picked up, and that is sometimes important for us as well. So the current GBM therapy landscape is that the treatment goal should include maintaining function and prolonging life, and therefore the most important thing is surgical removal of the tumor, debulking for operable tumors, and destruction of the residual cancer cells after surgery with whatever we've been doing. Control of signs and symptoms, very, very important. Achieving maintenance or improvement of patient's function and prolonging life. Treatment options currently limited today is, as we've already discussed, radioneurosurgery, whole brain radiation, temozolomide, chemotherapy, and clinical trials. So this patient on 3rd February in the follow-up 2021, these are the scans, and since we don't have any radiologist here, I will just read out the report. This MRI showed nodular enhancing lesions in the left anterior temporal lobe with collapse of peripheral enhancing cavity on the background of diffuse infiltrating lesion involving ipsilateral anteromedial temporal region, insula, putamen, suggestive of significant regression, favoring treatment response. So 23rd July, this lady came with headache, nausea for 3 days. Clinically, she had no focal deficits. So we are dealing with probably a recurrence. So how often do you see recurrences in GBM? Again, any table can take this because that doesn't differentiate socioeconomic status.
I think all patients will invariably recur.
Yeah,
Almost 90-95%. Everyone you see recurring.
correct. So this is some statistics to show you when they recur and why they recur. And despite all the therapies that we give, usually the recurrences are within 2 centimeters of the resected margins. And this is just showing you the overall survival months after diagnosis. So are there any mechanisms by which you can decrease recurrence? One, you already heard about lomustine. Anything else, team A, B, and C?
So there is some data to give temozolomide as adjuvant for more than 6 cycles,
Right,
particularly if MGMT positive.
right. B?
Yeah, the same thing I want to ask, how long we can continue with after 6 cycles, because it is methylated. So maybe we can, but I don't think there is a strong evidence or something like that.
Team C?
In MGMT methylated tumors, there is retrospective analysis to say that giving it for 12 months probably might have benefit. And if we look at decreasing recurrence, probably there are 2 studies, major studies showing that adding bevacizumab to temozolomide along with the RT is shown to improve the progression-free survival, but it's not going to improve the overall survival. If you're looking at point of only decreasing the recurrence, probably yes, but it doesn't alter the survival.
Correct.
Bevacizumab and temozolomide.
So many of us do use it for more than 6 months, and some have used for 1 year as well. That's one of the things. And the point about bevacizumab, this is the data that this is one of the studies that is published in Neuro-Oncology in 2016, talking about use of bevacizumab along with radiotherapy and temozolomide. This is upfront showing you that there is some advantage. And conclusion was that this exploratory analysis suggests that addition of bevacizumab to standard glioblastoma therapy prolongs PFS and OS as well, with those who have received 1 line of therapy. This is one more paper talking about the use of bevacizumab upfront, and they found that this can prevent early deterioration and prolong survival in partially resected. So I think most GBMs are not completely resected, as we understand, because they are interested in decreasing the neurocognitive deficiency which can occur because of extensive removal. So maybe this is one of the ways. And this is again showing you based on whether they got bevacizumab or not, whether there was complete resection or partial resection, and showing you that the addition of bevacizumab did help in those patients where the resection was not considered optimal. So the conclusion from this study was that add-on Bev can prevent early clinical deterioration in those patients, and this may contribute to prolonged survival, especially for those patients with poor performance status. So this is another study, Bev and temozolomide upfront, and again this study concluded that for newly diagnosed GBM, age more than 70, KPS more than 60, treatment with temozolomide bevacizumab has shown to produce promising survival benefits and tolerable side effects. I think all of us are today familiar with using bevacizumab, and the side effect profile is pretty all right. So this is one of the ways by which we can decrease recurrences. Again, important when you add a new drug is the quality of life, and this study actually looked at the quality of life of these patients, and they found that this addition of bevacizumab did not worsen statistically significantly the quality of life in terms of global health status, physical functioning, social functioning, motor dysfunction, or communication deficits. So this is an option that we have. One question we always talk about is treatment without tissue diagnosis. So what are your comments, team A, B, and C? So just going back, what are the tumors you can sort of treat without having tissue diagnosis?
No, in cases where it is very inaccessible, it's going to be deteriorating if you go in and do a biopsy, or it's going to be very difficult. Maybe we take a consent and go in with radiation. There's no other option left.
Okay.
In such cases we do.
Okay.
For a GBM, supratentorial, extremely rarely, most often we do get a stereotactic biopsy done.
Right.
And the tissue is not just for diagnosis, it is, as we said, for the
Absolutely.
further PCR or for the NGS. So to be avoided if possible, if absolutely impossible, then it has to be a multidisciplinary team discussion along with the patient and decision.
Yeah.
In some cases like pontine or something, the
Pontine
location is there.
gliomas,
Yeah. So
yes.
in that case, I think if two radiologists concurred, then we can go ahead with without tissue diagnosis and we can start the treatment.
Team C, any further thoughts?
I agree.
Okay. So, it's not that always taking a piece of cancer is no piece of cake. Like you said, in people where it is very difficult to do. And do we have evidence to this? So this was one paper which is published talking about patterns of care and clinical outcome in assumed glioblastoma without tissue diagnosis. There's a population-based study of 131 consecutive patients. And the conclusion was that this paper looked at data from November 2012 to 2016, all consecutive patients presenting with a suspected glioblastoma in the western region of Sweden. And this is, as I told you, a population-based study. And of the 378, 131, that is 35%, met the inclusion criteria for the present study, and they were treated without histological verification. And the conclusion was that apart from high age, poor performance status, they had more severe comorbidities and extensive tumor spread. Even for this poor prognostic group, upfront treatment with temozolomide showed benefit. So there is always the subset of patients where you can't have tissue diagnosis, and as you said, two radiologists concurring, you can go ahead with treating these patients without a tissue diagnosis. So back to our patient, almost a year since her treatment. July 23rd, she presents to us with headache, nausea for 3 days. Clinically, there's no focal deficits. And this is the MRI done on 23rd July 2021. And I'll read out the report for you. There's minimal left anterotemporal pile enhancing nodules with perifocal edema, focal gliotic changes in left temporal lobe with dilatation of ipsilateral lateral ventricle. So this is the MRI report. Would you want anything else done, team A, B, and C, or are you happy with this report? So this patient was actually seen by the radiotherapy friend of mine who was treating, and he saw this report. So if you see this, would you ask for anything else? Okay, what happened was...
Spectroscopy?
Yeah, that is one thing. So my radiation oncologist was really not very clear as to what this was, and discussion with the radiologist again was not conclusive. So what he asked was a MR PET scan. So this was done on 4th August, and this showed increased tracer uptake in the left anterotemporal pole, SUV of 14.5, with adjacent multiple areas of hypermetabolism in the left hippocampus, parahippocampal, gyrus, temporal stem, and left peri-insular region. So very clearly telling us there is recurrence. So how will you treat this patient? Team A, B, and C.
If possible, PS is very good, probably look for a resection again. That would be my first option.
Okay. B, resection.
If a safe resection is possible, it is a left side, it's a dominant lobe when surgery is done, so that all those parameters have to be assessed in the safe resection. Options with the safe resection include a gliadal wafer if the patient can afford it. It's very expensive, maybe for that table. That would be the way to go. If resection is not possible, not safe, patient is unfit, which is very often the case in recurrent GBM, then re-challenge with bevacizumab if it was used before, or else try bevacizumab plus irinotecan.
Right. Team C?
Yes, agree.
Okay.
Surgery is one option, and also re-irradiation also can be considered.
Yeah. So this patient actually, Bharat, she had very good performance status, and after lengthy discussion with her, they were really reluctant to undergo surgery first because it was within an year, but then we convinced them, so she underwent surgery again. So the role of surgery, biopsy, histology-based treatment. So recommended.
So my only comment here is,
I
know you've done the MR PET and stuff. We are all medical oncologists here. So for us, the recurrence based on imaging is a little bit of a difficult situation,
Correct.
but to differentiate between radiation necrosis.
Correct.
Luckily, we have a very dedicated neuro-oncologist. But even in spite of that, it's difficult many times. So surgical decision should not be taken up very lightly also.
Absolutely. That is why the importance of a multidisciplinary team approach for all these patients. That's why I said we don't have a radiologist, so I'm reading out the radiologist report that was given. And that's a very, very important point, Bharat is absolutely right. So the recommended treatment approaches, of course, if you have a clinical trial, that's the best thing that you can do for your patient. Systemic therapy, surgery for resectable asymptomatic lesions, radiation, we already discussed that, and palliative care, of course. Those were poor performance. Bevacizumab, we already discussed. I showed you the evidence in the earlier setting, and this is the rationale. We know that VEGF is overexpressed in these tumors, and you have combinations of bevacizumab, irinotecan, bevacizumab, temozolomide, and there is evidence for all these. So this is one study which looked at lomustine plus bevacizumab. This is in recurrences, and this is the EORTC 26101 study, and you can see the randomization here. And this is looking at the overall survival, and this is the progression-free survival. So there is some benefit of this combination in recurrent glioblastomas. So by this time we got this histopathology report. The histology was again very similar, GBM, not otherwise specified. So any role of checkpoint inhibitors? I'll start with C here.
In recurrent setting, there is a comparison between nivolumab and bevacizumab in recurrent tumors, but that has been, there's no significant improvement in the nivolumab arm. The progression-free survival, overall survival were similar between the two arms. So as of now, going ahead with bevacizumab would be a better option.
Yeah, as you said, there is some PFS advantage, but no overall survival advantage. This is the other study which had low dose bevacizumab versus nivolumab plus standard dose bev, and again this showed some advantage, but again it's not come into routine practice. The other interesting molecule is regorafenib, and this has been compared versus lomustine, which is one of the important drugs that we have always been using, because that's been there with us for a long period of time. And now that regorafenib is available as a generic brand as well, maybe this will show something. So this is just to show you that there is in fact an overall survival advantage when you use regorafenib as compared to lomustine. 15 months versus 38 months. So this patient, like I said, she was convinced that she should undergo surgery. She had a re-exploratory left frontotemporal craniotomy with neuronavigation, decompression of the insular recurrence. This was done on 30th August and discharged on 2nd September. So this is the repeat histopathology again, like I said, no change at all, very similar to the primary. So what is the role of molecular profiling in GBM? Team A, I think this is not under the government scheme, so we will not discuss for this patient. Bharat and Team C, Ashish?
We should do all the patients, because after second line, after recurrence, we hardly have any further plan for that patient. So we should do molecular profiling for such patients.
Okay. So would you do an NGS or any specific panel that you won't want?
I think
Team C?
I think NGS can be done. There are certain signatures which are very particular for GBM, like TERT mutation and EGFR over amplification and deletion of 10 and addition of 5, I think. So these are very specific for glioblastoma multiforme, and they tend to have a poorer prognosis. And there are many reports where even GBM has microsatellite instability, high reports. There has been reports where they are now trying IDH inhibitors in GBMs where it is positive. There are multiple options which are getting available. So getting a complete profile done might have access to any of the new. It's more of like a tailored therapy.
Correct. And since your patient can afford anything, academically also you'll be contributing to the changes that are there. Yes. So this is just a slide to tell you what changes have been described, and you already mentioned IGH, TERT, EGFR is one, and P10 deletion is the other one. So again, the cost of looking at genomic analysis has rapidly dropped over time. This is just showing you from 2007 to 2017, how it has dropped and how the information that we are getting from these genomic analysis has rapidly increased. So I think we must take advantage of these things and definitely try to see what's happening in our patients with recurrence. So this is, again, some of the novel target agents with the TKIs for GBM. They've actually detected mutations CDK, PIK3, and KRAS as well. So this is a phase 2 study looking at the role of palbociclib. This is looking at PIK3 inhibitors. This is again a phase 2 study, but again emphasizing that these things are rapidly coming up in GBM as well. And in fact, this article actually said that they compared all this to what is happening in non-small cell lung cancer today. So back to our patient, she underwent NGS testing, and this showed an EGFR mutation of, as you can see here, A289T. So have anybody seen this particular mutation, or have you got this in recurrent settings? What is the most common things? I will start with C. If you have done for your recurrent patients, what are the most common changes that you have seen?
I don't have patients.
Okay. Bharat, anybody from your team?
We have hardly done comprehensive NGS for GBM, so no personal experience in this situation.
So I was very lucky when this patient walked in and I was asked to discuss GBM in this forum. So this is a pretty rare mutation that is seen. And this is just to show you the EGFR pathway. We are all very familiar because we've been targeting this pathway in the lung cancer for a long, long time. And this is a list of all the trials that are ongoing, accruing for this EGFR mutations, and I'll just not go through them, just to show you how many of trials are ongoing today. Starting from EGFR TKIs to chimeric T-cell therapy, CAR T-cell therapy, and antisense nucleotide as well. So this is one article looking at the third generation EGFR inhibitor, that is osimertinib. This can overcome primary resistance by continuously blocking the ERK signal in glioblastoma. This is actually looking at spectrum of EGFR aberrations and potential clinical implications. And this is from pan-cancer analysis. And if you see this, other than lung cancer, GBM is the next one that have extensive EGFR changes. And this is looking at what are these changes. They can be amplification, mutation, multiple alterations, or deletions. So again, you see the first bar is for GBM. And this is looking at different parts of the EGFR receptor itself. It could be amplification or gain or diploid or deletion. So this is in different parts of the receptor. Either it is the extracellular domain, intracellular domain, transmembrane membrane domain, or the fusin-like domain. So there is so much data available today. So this is from the My Cancer Genome, talking again about EGFR deleterious changes. And if you see here, diseases with this particular EGFR A289T mutation, again, as you see here, the most common is in glioblastoma, and it's been described in several other tumors as well. So this alteration of EGFR is there in 31.54% of glioblastoma patients, and this particular mutation 289T is present in 1.16% of all glioblastoma patients. This is a very nice article. You know, we know that we have detected a mutation, we have a TKI which can work on it, but they found that it is not just that you see the mutation and use a TKI. They found that there are various changes that occur in the receptor itself when you start treatment, and this is a wonderful article. If you can get a chance, I would advise you to go through it. They're talking about allosteric, rationally targeted therapy for these patients, and what they say is if you just use the TKI, it may not do the best, and you need to target the extracellular domain and the intracellular tyrosine kinase, and therefore you need to probably combine a TKI with a monoclonal antibody. The other pathway that can produce resistance to the EGFR inhibitors is the IGF-1R pathway, and this is one of the papers talking about blocking this pathway as well. So I think I've come to the end of this. So where are we in cancer therapies? Empirically determined therapy is going the dinosaur way, but the molecular-based therapy is definitely coming up. As I've shown you in this GBM, I think, as I told you, we are really going up towards what we are doing in non-small cell lung cancer today. So thank you very much. And if any of the panelists have any final words, otherwise I'll ask Rakesh to give his expert comments. Any comments from you? Yes, Rakesh, all yours.
Thank you very much, Dr. Govind, Babu. I think you captured it beautifully, especially the second half. And it gladdens my heart that there is so much interest out there. And neuro-oncology has been a little bit, we have struggled to get the medical oncologists on board, but I was absolutely happy that everyone is at par with the latest. I'll just make a few comments building on what you already showed. Although GBM still, there's no doubt it's one of the most difficult solid cancers, but data is slightly getting better in the sense that we used to say about a year, which you also showed. The median survival in most of the large cooperative study groups is anywhere between 15 to 17 months. It's about 2 to 3 months better than what used to be in the past. In our TMH data also, it is actually 17.5 months based on various series we have done. The 2-year survival is about 26 to 28%, and MGMT absolutely right. MGMT methylated patients, 46% 2-year survival. The 5-year survival is not now less than 5%. 5-year survival is actually 10%. It is double what used to be, say, 10 years ago. It's not a huge number, but still slightly better. And in the TMH data, which we presented in ASCO one of the years, it was actually 11%. The original Stoops trial also looked at the 5-year survival, it was 9.8%. And if you have MGMT promoter methylated, it can go up to 15 to 16%. So imagine a 15% grade 4 glioblastoma more than 5 years. So there is a small cohort of patients who do slightly better than others. We already discussed the IDH. I must inform you the IDH mutation, which is now pretty standard in the IHC, captures 90%. In 10% when you have a strong clinico-radiological correlation, especially in young people, but slightly different MRI findings than the case you mentioned. You could do the sequencing, you just need a small targeted sequencing, doesn't cost much. We have published the ISNO guidelines on it in the Neurology India 2-3 years ago, led by Vani Santosh. And nowadays, the 2021 recent MOST classification says that if you have IDH mutation in what looks like a grade 4 glioma, you do not call it glioblastoma. You call it now grade 4 astrocytoma, to give a slightly connotation that grade 2, grade 3 have actually become kind of redundant now. It's more like a molecular determinant. For example, even grade 2, grade 3 astrocytomas, now they are called lower grade gliomas. So they have the identical mutation of IDH mutant plus ATRX loss. If you have ATRX retained, either it can be a glioblastoma or it can be actually an oligodendroglioma. 100% oligos have to have IDH mutation positive. They have to have 1p19q co-deletion, and sometimes nowadays we also do TERT mutation. If you have the what we call triple mutation, even if it is a grade 3 anaplastic oligo, the median survival is now 17.5 years. So although it is still called a high grade glioma, grade 3 oligo, but look at the impact of histology and molecular information. And if you have these molecular informations with the advent of the recent trials like CODEL, the survivals can be extremely gratifying in this subgroup of patients. TERT was mentioned very nicely by somebody, and TERT mutation is very interesting mutation. In oligos, if you have TERT mutation, it actually confers a survival advantage. But unfortunately, if TERT is mutant in GBM, which sometimes we do, especially IDH negative patients, they actually confer a worse prognosis. But there's a lot of data out there. There's a lot of effort to target the TERT as well as a therapeutic option. And the next few years, we might see something on it. There are 3 distinct glioblastomas which have been profiled in the last 3 or 4 years, and where there are therapeutic options. Some of them you briefly mentioned, I just want to build on, because they will increasingly come into the domain of neuro-oncology and medical oncology community. The number 1 is called an epithelioid glioblastoma. Epithelioid glioblastomas are typically seen, actually I also wondered briefly in your case, because they occur in late 20s, 30s, early 40s. They can be in the temporal lobe. They are cortical based. They have a lot of hemorrhage, and they have a classic radiological feature and a classical morphology. But what is beautifully demonstrated is that almost 80 to 90% of epithelioid glioblastomas would demonstrate a BRAF V600 mutation. So that is music to our ears, because as we have experienced in so many other solid cancers, there's a lot of effort in using the BRAF inhibitors, particularly the dafrabenib, and also using MEK inhibitors sometimes, which can be seen in pleomorphic xanthosarcoma grade 2, grade 3, which again has 70 to 80% of patients having BRAF mutation, and about 15% of difficult pilostic astrocytomas also occasionally can have not BRAF mutation positive, they can have BRAF fusion positive, and where that MEK inhibitors, particularly the salutinib and the trametinib, have been shown. So I would request all of us to impress upon the pharma industry, Novartis for example, to try to get the drug, try to make some effort to make it on a compassionate basis. I have about 15-20 patients on the drug, on the dual inhibitors, typically the younger people, but we have to work collectively on it. So this is one variant which has, although it is grade 4 GBM, which will show better survival. The second one has been already, you mentioned in brief, is the diffuse midline glioma. So now we don't call it diffuse pontine glioma or DIPG or brainstem glioma. They have to be molecularly characterized, and about 80% of them exhibit what is called H3K27M mutation, the histone mutation. And that can be also seen in the pons in children, but in older people can be also seen in other midline structures, for example, thalamus or near the genu or the corpus callosum. Has slightly better prognosis than the classic brainstem gliomas, but even in the childhood brainstem gliomas, there has been a small effort that we must try to biopsy them if it is safe, to demonstrate the H3K27M mutation. And there is a fascinating molecule which has been discovered. It's a dopamine antagonist. It's called ONC201, and I have seen several publications on it. There are ongoing now. We have gone to ONC206 phase of the study, which are basically not randomized trial because the number of patients are small. We are collecting the data on the phase 2 basis, but we know the survival of pontine glioma and midline glioma anyway, so you don't need a randomized trial. If it shows a survival advantage, then it will become the standard of care. It is again, unfortunately, not available in India as yet, but again, we are trying to get the drug from some other market. So ONC201 is an oral medication. You have to do it weekly or 2 weekly, and if somebody has a pontine glioma, they are welcome to get in touch with me or somebody else, and we will try to get those patients some advantage. And 2 or 3 of my patients are still going on for the last 2.5 years on this molecule in spite of having a midline glioma. The third mutation which has captured the imagination recently, and I'm happy that it was adopted by the WHO 2021 classification update as well, is what is called hemispheric glioma, typically seen again in young people. It is again a histone, but not the STK271. It's called G34 mutation or hemispheric gliomas. And when you run the NGS panels, or even if you run a kind of a oncomine type of a focused assay, please do mention to include the hemispheric, especially if they are on the hemisphere, which our patient also had. And a recent paper 2 weeks ago in the Cell has first time ever demonstrated 2 very important mutation pathways. One is the PDGFR and another is the CDK4/6. So both the CDK4/6 inhibitors as well as the anti-PDGFR inhibitors are likely to play a dominant role in this cohort of patients with hemispheric H334 glioma. So these are the 3 distinct GBMs which have shown a particular therapeutic target which we can exploit in the next 5 years, and watch out for the space. It's going to be a very, very interesting domain in this GBM. You mentioned beautifully about EGFR. All of us had great hope on EGFR. The EGFR which captured the imagination of everyone was EGFR V3 mutation, which was discovered, published in NEJM about 7-8 years ago. The phase 2 data, what is called ACT 1, 2, 3 study, showed 2-year survival of 50%. And as in your case, it's only about 1.1%, but V3 was actually present in 17% of GBM patients, was a substantial number. But unfortunately, GBM is a GBM. We embarked on a large 700, 800 patient trial, which actually I participated in PMH as well. We contributed 30 odd patients to that trial. And there was a vaccine against it, which we called anti-ridopapitumate, anti-EGFR-B3 vaccine, but the survival was absolutely no different, and unfortunately, it has not seen the light of the day in the clinical practice. Nevertheless, there is a lot of data on anti-EGFR therapies combining with, actually alone it will not work, as you rightly said, you have to combine it with something and then it might work. A word on bevacizumab, although you mentioned there is some data, but actually speaking, when we did the randomized trial, there is back-to-back papers in NEGM. One was done by Pharma, which is called EVA-GLIO study. Another was the cooperative group by RTOG 0825 study. A large randomized phase 3 data, more than 800 odd patients. Upfront BAV versus BAV only at the time of relapse in a newly diagnosed GBM. Absolutely no difference in overall survival. In fact, overall survival is slightly worse in the bevacizumab arm. So there is very little data, to be honest, based on evidence that you should use BAV right at the beginning. We tried to look at in unmethylated cases because they were the difficult ones and had more angiogenesis also, and also looked at what is molecularly determinate angiogenic tumors called the mesenchymal GBMs. There was a study called GLARIS study published in JCO 3-4 years ago. Unfortunately, it was a negative study. So I use a lot of BAV. I have about 400, 500 patients now, but we typically use it at the time of relapse as a quality of life, which you rightly mentioned, but not so much in the newly diagnosed setting. In fact, there is some data that if you combine with radiation, there might be actually a less effect of radiation because of the normalization of the vasculature. The temozolomide was discussed already, whether 12 months or 6 months. The 12 months, 6 months randomized trial in Spain, published in ASCO last year, presented in ASCO, was actually a negative study. We do use it though, unfortunately, as for the lack of any other option. Glidal wafers, again, GBM data not very good. You could use in anaplastic oligos. And a couple of things, the role of MDT, the role of determining the pseudoprogression, the RANO guidelines, the subventricular zone, vaccine, CAR-T-LC therapies, and these are the things that are being discussed at this point of, and finally, of course, the quality of life and palliative care. Thank you very much for the
Thanks,